Excellent. Well, good morning. Welcome, everyone. We'll go ahead and get started today. Thank you all for joining in. We are going to have a good and busy morning. Our Children and Youth System of Care State Technical Assistance team is happy to dedicate today to child and family teaming. It's going to be a busy and fast-paced webinar. You can see here the list of partners, and we will continue to introduce partners as we go through the morning. Our agenda is to provide some updates. So System of Care team members will provide department updates, and that's a good time. If you have questions, you can use the chat. You can also use the question and answer Q&A box on your Zoom screen to type in questions. We'll be putting a lot of resources into the chat throughout the morning with links and documents. Just want to make sure everybody knows how to save the chat. There's three little dots on the right-hand side of the lower right-hand side. And if you go over there, you can typically hit save chat. Sometimes that doesn't show up quite right, but you can always try to save the chat. And if you would like to, you can also just select everything and copy and paste it. If you have any questions, we've got myself, Nancy Haper with UC Davis, and then Mike Kari is also on the phone. I guess the webinar, Zoom, and we can help you with technical difficulties or questions as they come up. With that, so I am Nancy Hafer. I'm with UC Davis, the Resource Center for Family Focused Practice. I'm here to help kick off the webinar. And again, if you have any questions, you can just let us know. And actually, I get to be in charge of the polling questions, and I'm going to turn the tables all on you for a minute. And I'm going to ask you, let's see, I'm going to allow panelists to vote. And I'm going to ask you all, which system partner are you from and what area do you represent? Thank you all for helping to find the polling questions this morning and being engaged. This group is always really participatory. So thank you for being involved. And if you would like, you can introduce yourself in chat. We are having what the weather is looking like outside of your window. It's nice to network, say hi to colleagues. Okay, I'm going to end the polling and we'll show we've got most folks today are from behavioral health, mental health. Let me see, I think I can share the results here. So you can see who is sharing the time and space with you today. We've got lots of behavioral health, mental health, child welfare, education, juvenile probation, regional centers. No one identified from tribe or tribal partners. So let's reach out and see if we can get some of them here next month. Areas that are represented, program, policy, couple of people, thank you for being here for data folks. We've got some overlapping multiples and others. If you're an other, why don't you let us know what the other is representing in the chat. Okay, so we are going to do some updates, and then we've got two good presentations from the System of Care Technical Assistance team, and then from San Diego, all focused on child and family teaming. And then we'll have time for Q&A. And let's see, to kick us off with updates, we have the California Department of Social Services.
I believe, good morning, Ashley Franklin. I am part of the Children and Youth System of Care State Technical Assistance team from the California Department of Social Services. I think Richard was going to jump in and share a brief update before we pass it over to Kelly for the FFPSA overview.
Yeah, I think it was just an announcement. Thanks, Ashley, that some of you have participated in the Breaking Barriers symposiums over the last 3 or 4 years, and there's an expanded approach to breaking barriers this year that will begin actually in February with a series of master classes that are very much aligned with the system of care implementation work that you're doing locally. And so what we'll do is we'll put in chat here momentarily a link to the Breaking Barriers page. These are master classes where you'll be able to bring your system of care team into a local conversation for an hour with other counties and with 2 or 3 folks in a particular topic that's aligned with, again, the 2083 work that on some level Breaking Barriers has been supportive of over the last few years. So look in chat momentarily for that link, and you can register for these free masterclasses that are in support of your local work.
Okay. And next, I think Kelly will share a bit about FFPSA.
Thank you, Ashley. Thank you all for letting me join you today. I know I only have a couple of minutes to talk about FFPSA prevention services, and I know we have some slides that probably need to be teed up here.
It should just be the next slide, Nancy.
Okay, sorry. Thank you.
Thank you.
Awesome. Yep, thanks.
So I think this is probably going to be the briefest overview of FFPSA prevention services. So I'll do it as quickly as possible and as clearly as possible. So many of you may have already been hearing about the Family First Prevention and Services Act, probably more in relation to STRTPs and the changes in law that are made to those programs. But the Prevention Services Program is basically the ability for us to draw down some additional Title 40 funds to use on prevention services. And currently that's happening in a pretty limited scope. So the program is really designed to serve those youth and children who are at imminent risk of foster care. And the services available to those families really are to make them, or to give them an opportunity to have availability of substance use treatment programs, mental health services, and in-home parenting skills programs. The programs are expected to be evidence-based, and they are evaluated by the Federal Clearinghouse and are intended to meet rigorous evaluation requirements. All of these programs and services must adhere to and monitor to those programs selected so that they're delivered with rigorous model fidelity. The federal government is expecting a 5-year prevention plan from each state, and they'll be approving those plans for implementation. It's an optional program for each state, but they're approving based on a couple of criteria. Actually, it's more than a couple. It's quite a bit of criteria. The expectation is that states are designing a continuous quality improvement process to monitor those programs used in the prevention plan. Rigorous and well-designed evaluation of services are to be expected. And in addition, there's a number of federal reporting requirements that we have to meet in order to get approval for this prevention plan. This includes per child fiscal reporting requirements, which is something new to our services that we've not had to provide in the past. So we are in the process of developing a 5-year prevention plan. It's a short time frame, and we're in conversations with stakeholders as we speak. We're developing a first draft of our plan to be shared within the next several weeks. And we are hoping to have a plan for submission to the Administration of Children and Families by summer. And we'd like to see that plan be approved by the fall. In fact, this week we are having summits. We're planning for summits to happen next week. So you'll see on the screen there, it says February 9th and 10th, where we're convening county teams to talk about really what does it take to put a prevention plan together, and then really having some in-depth conversations about a couple of things. One is that who we're going to serve, so our candidates for prevention. These are the families I talked about where children are in imminent risk of foster care. And then we're also going to be talking in depth about what evidence-based programs that will be included in the plan. Next slide, please. And so I was asked today to come and talk about really what this might mean for you all. So I understand that you all have interagency leadership teams, and that, via this system of care approach that we're providing, that this is really a container required planning, alignment, and the management of the Family First prevention and service. Through this process, you all will be able to really give input into the identification of the eligible populations, those candidates that I talked about just a minute ago, and really give input to the services that we can offer them, who will be providing those services, and then how to leverage and account for the various state and federal local funding that's required. This is all really fitting very nicely with the system of care approach via planning and execution. The system of care MOUs that you all are working on to develop gives attention to how the systems handle things like eligibility, assessment, coordination of care. All of those things are designed to support the very type of interagency work that FFPSA requires. And I put a quote in there from your state 2083 toolkit. This information really ensures that system partners, programs, and policies reflect a coordinated, integrated, and effective delivery of services for children, youth, and families. And so I hope that there's an opportunity here to really see that the system of care approach can not only utilize FFPSA to demonstrate the effectiveness of system of care, but on the flip side of that, the FFPSA really can benefit from the structure that you all are putting together in order to really make FFPSA Part 1 successful when we come to implementation. I know I only had a few minutes, and I know that was very quick, super high level overview of the prevention services program. I hope that this helps make connections for folks and really gets you all thinking about how the system of care can support FFPSA and vice versa.
Great, thank you, Kelly. I appreciate your time. So let us know if there are any questions. We do have one, Kelly. Is there any information on registering for the summit next week?
Yes, I can share our summit flyers with the group here. Just to be real clear, day one is really a learning opportunity for folks. This is where I think it's the most appropriate for folks who are less familiar with FFPSA to really get up to speed. It's level setting and really getting folks to be thinking about how do we determine where, how California will approach candidacy, and really thinking about what it takes to select an evidence-based program, what is required for things like evaluation and model fidelity. Day one is a really ideal place for folks to get up to speed. Day two is more of a working session. If you're a county agency working with your partners and you're really, already well-versed in FFPSA, it's a working session for giving input, but it's designed to really target those folks who are responsible for delivering the services from a county 4E agency lens. So day one actually is probably the best place I'm thinking for this group. So we'll share those flyers and get that out to folks pretty quickly.
Excellent, thanks, Kelly.
Sure thing. All right, thanks for having me, everybody.
Yep, thank you. We do have, I'll give an update on the Partnership for Wellbeing Institute that we are going to have on June 3rd, 2021. So it's in, I think that's about 5 months away. It's on Thursday, June 3rd. We will have, it's our third virtual Partnership for Wellbeing Institute. So we took what was supposed to be the 3-day in-person institute, and we have modified it into virtual offerings. So please plan on attending. The last two have been really well received, and this institute in June will particularly highlight and feature the family panel, which is one of the most well-loved and respected parts of the institute. So we have the family panel will be held in June, and then in addition, we are seeking nominations for a series of awards, and I'm going to put all of them into the chat window right now. But we will be offering awards for parent partner, youth partner, integration awards for both organizations and an individual, and a wraparound champion award. So in the chat, you've got the award criteria and categories. You have the nomination form, and then also most importantly, how to nominate a family to serve on the family panel. So we look forward to seeing all of you on June 3rd, again, in this Zoom virtual space. So we have a couple of more updates, but let's break this up and do another polling question. So I'm going to launch polling for y'all. We've got do local system school-based and regional center teaming processes align with child welfare and behavioral health processes in order to assure that a single team is developed. Please share in the chat examples of what is working and where there are challenges. Excellent. Takes a little while to read that question, so we'll expect answers to really start flowing in. It's a great question. Right now I can see that about half and half are saying yes and no. And this is the job, right, is to align everything together for a single team. We got some challenges that are starting to pop up in chat. I'll give it another second. All right, I'm going to end the polling. And I'm going to share the results. You can see a little bit more than half, 61% said no, not yet. I'm going to say not yet instead of no, right? Growth mindset, all kids are learning it in school. We'll say it's just not yet. We're working on it. And 39% of you have said yes. So we'd love to see some of what's working and what some of the challenges are in the chat. Here we've got they're starting to join our interagency teams. That's fantastic. Excellent. Great. Okay, so let's move on to our next update. Christine, do you have anything from the Department of Developmental Services?
Hi there. Yeah, I just wanted to share a webinar series opportunity for from our early start section. It's a remote assessment, perks and problems, and they're doing ongoing webinar series until May, I believe. And so I'll put the flyer for the training series in the chat, and some contact information if you have more questions. So definitely take advantage of learning more about telepractice services and how that can best serve our families and youth. Thanks.
Great, thank you, Christine. So I do want to pause and make sure everybody can read through the chat because there are some really great comments in there. At the same time, I think this might be a good time to have another polling question since we're using the chat window right now. So this one is, does your local MOU satisfactorily address barriers to consistent and uniform teaming and service coordination? And again, if yes, please put in the chat what steps have been taken to address these barriers. If we'll change that next time to not yet. If not yet, you can put in some ideas for that. And then unsure. Unsure, but learning. We'll change that unsure to I'm checking on that. Need more information before I can answer. Okay. Here we go. Not yet, but moving in a positive direction. Great, Denise. That's excellent. Okay, so the looks like I'm going to end the polling here and share the results. It looks like there's a lot of folks who are not totally sure how this is working, or if not working, but if this does address the barriers to consistent uniform teaming. So something to go and find out more information about. Still learning, Christine, great. And currently in the process of updating those MOUs. Fantastic. Work in progress, aren't we all? Okay, we now have some system of care updates.
Good morning. Diana Wagner with Department of Social Services. And just want to share that we did put out a survey in mid-November of 2020 that ended on December 11th. And that was put out to the interagency leadership team. And they were able to respond. We did get responses from Child Welfare Probation, Mental Health, Regional Center, and education partners alike. So everybody was giving input to this survey. What we learned from the survey is that there was a need for additional information for Part 3, which is the data and information sharing, Part 9, resource and fiscal management, and Part 7, alignment and coordination of services. And so we are going to be working on developing some assistance to the interagency leadership team in those 3 specific areas. So more to come on that. Thanks, Nancy.
Sure thing. Sorry, sometimes the unmute is a long ways away. Okay, we are now moving on to talking a little bit about AB 2083.
Hi, everyone. I'm Lindsay Merwin with Department of Healthcare Services. If you are new to AB 2083, it is an Assembly Bill. AB 23 was authored by Assembly Member Cooley and was chaptered in 2018. The intent of the legislature in adopting this bill was to build upon the current CCR implementation effort by developing a coordinated and timely and trauma-informed system of care approach for children and youth in foster care who have experienced severe trauma. The bill requires county to develop and implement a memorandum of understanding, the MOU, setting forth the roles and responsibilities of agencies and other entities that serve children and youth in foster care who have experienced severe trauma. Our team has developed MOU guidance to assist counties. This guidance is posted on the California Health and Human Services webpage, which there's a link on the next slide too. The state interagency team has also released All County Letter 2063, which describes how counties and local partners can request technical assistance. And then the team is currently working on the gap analysis and multi-year plan. And then this is the link that I was talking about, where we do post our presentations on this website, and we also provide some updates as well. Back to you, Nancy, I believe.
Okie doke. So I've got slide number 11 is coming back to you, Lindsay. For context.
Thanks, Nancy. Yeah. Thanks, Nancy. Okay, so just some context and background around teaming. Teaming activities, which includes engaging members, coordinated care, sharing information, planning, and monitoring. These all occur within the service delivery frameworks of all children and youth system of care partners. Aligned, connected, and fluid teaming, planning, and service delivery is the cornerstone of children and youth system of care work. Teaming and team meetings are not the same thing. Teaming is a process based in engagement, trust, and listening. Genuine teaming and the trust it creates is the single most important element of healing. Next slide, please. Awesome. Thank you, Nancy. So these are the 5 areas within the MOU that support teaming activities. Part 3, information and data sharing. Part 4, screening, assessment, and entry to care. Part 5, child and family teaming and unified service planning. Part 6, interagency placement committee. And Part 7, alignment and coordination of services. And then I believe the next slide, I will be passing it to Renzo.
Thank you, Lindsay. So as Lindsay shared in regards to the background and context for teaming under Children and Youth System of Care, one of the starting points for engagement with your child and family team meetings is a recognition that teaming already currently occurs in all of our service sectors and at times across some of those service sectors. So as an example, in public education, and we're highlighting public education because traditionally public education has not had a role in system of care, but under AB 2083, we're envisioning children and youth system of care in a much broader fashion to really focus on having the ability as a county team with all our different partners in this larger children and youth system of care work, to have them focus on providing whole child care so that subsystems within public education should now start to be envisioned as being part of a larger county-wide system of care. So within the public education space, we already have multidisciplinary teams that are used to address academic and social needs of students. These processes and teaming engagements lead to the development of individualized plans for students, and these include use of student study teams, Section 504 teams for students that have disabilities and have accessibility needs to access their public education, individualized educational program teams, IEP teams, for students with disabilities that qualify for special education and related service, and other types of individualized education teams that are present within schools and school districts. In social services, there's also multidisciplinary work that happens, and those multidisciplinary teams are used to create and implement care plans for youth that are in the foster care system. So child and family teams, multidisciplinary teams, safety organized practices, and meetings such as interagency placement committees that take place. So the idea with AB 2083 is to look at how we can connect these teaming processes across the different service sectors. And one of the possibilities is to take a look at your child and family team meetings practices to use those as an engagement process to connect to other system sectors to allow the child and family team meeting to be a place where the information from those separate teaming processes can be brought in, and see if you can connect those teaming processes in a more of a comprehensive system-based approach rather than having different subsystems working apart from each other. So we're trying to pull all these activities together into closer into being one. Next slide, please. So other examples of teaming that occurs in all service sectors in regional centers, we also have examples of individualized planning for regional service involved youth. The teaming processes include individual family service plans and individual program plans. Under behavioral health and mental health plans, we have child and family team meeting that occurs. And this happens for many youth that require intensive services. The focus for this particular level of teaming is on intensive care coordination, the provision of intensive home-based services, and being able to pull in therapeutic behavioral and therapeutic foster care into the broader care planning. So think of all of these separate subsystems and try to think of how we can utilize the child and family teaming process to potentially get us to a place where we're utilizing something akin to a universal services plan or a record of services that are being provided so that all the different service sectors are aware of the work that's being provided to support an individual youth and child, and to look for ways of being able to align the different services and supports that are being provided so that they're complementary of each other, and we're doing a better job as a larger system to provide whole child care. Next slide, please. The MOU guidance on teaming provides your interagency leadership teams with some information that might be helpful in the construction of your MOU under Part 5 for child and family team meeting practices and processes. So the guidance suggests that system partners provide a single unified teaming process for all youth in care. That to maximize this planning and family engagement, a child and family team process can be used. Typically, the agency with legal jurisdiction convenes the CFT meetings and documents CFT outcomes. This doesn't mean, however, that other agencies within your larger AB 2083 children and youth system of care can't request and ask for CFT meetings to happen to discuss the needs of a particular youth or child. The meetings should be coordinated with the appropriate placing agencies or in conjunction with any other intensive mental health services and the provider of those mental health services. All parties should participate as required and do so on time and in accordance with state mandates. You can find more similar type of guidance on the AB 2083 MOU guidance document, which is available on the Health and Human Services System of Care webpage. One of the previous slides has the link to that webpage. And this information can be found on page 19 of that guidance document, as well as some other information. Next slide, and we're transitioning to a different presenter who I can't remember off the top of my head. I'm sorry for that.
It's okay, Renzo. I think it's me. So as Renzo mentioned, there is the MOU guidance document, and in that document, it's organized really beautifully. If you haven't taken a look, highly encourage it. There's some guiding questions to help you with your interagency leadership team as you're developing your MOU, some kind of questions to lean into and tease out some of the thoughts or the planning that could go into the MOU for shared teaming. And so this slide, I can take you through the questions, but asking questions like, how can you leverage one another's systems? How can you, look at your current barriers for cross-agency teaming, and then really calling out each of those barriers and moving through a process to kind of align those barriers. Understanding what each of your system partners have to offer and in terms of services and supports. And so having these conversations will help you better design an MOU that meets the local needs. Next slide. Again, just some more kind of guiding questions. How is your provider network and natural supports? How are you addressing that in your local system of care? What does that look like for your local area? Looking at services like RAP and ICC, TBS. How are you utilizing and leveraging those in order to avoid more restrictive settings? Next slide. And so this slide here kind of references what should be included in your MOU. So when we talk about teaming and the CFT process, really outlining within your MOU the actual process for how those meetings are going to be conducted, who's the lead, how our partner agency is going to work together in a joint teaming process, having some kind of clear language around that, so there's a common understanding amongst all your partners, is really beneficial. When we leave it too broad, or our language is too, centric to one of our systems, then, we leave opportunities for, lack of clarity or consistency or agreements. So really defining that process is beneficial. And then also looking at how can you implement policies for cross-system planning to again, like Renzo had previously mentioned. So there's kind of that unified single teaming process. So what's the policies for that's going to kind of, or the plan that everybody can agree to. And then also, building within your MOU discussion around or language around how the CANs can really support that teaming process and assessment for all your system partners. So, the CANs is we have, system partners that are really familiar with it and use CANs. And then we have some system partners that are newer to CANs. So how can we bring them along, get them up to speed, and then really leverage CANs in a way that, that benefits the entire teaming process. Next slide. And I believe I'm passing it off.
Hi, Nancy. Can you move to slide 19, which should be practices for success? There we go. Thank you. So in regards to these practices for success, they can be found on the Health and Human Services System of Care site, which we'll be happy to put in the chat for you all. Under AB 2083 MOU guidance, and it can be found on page 20. And so because this is something that you can absolutely look at, I just want to go over some high level pieces. I think we all know by now that having natural supports as part of that teaming process is vitally important, so that when we as the agencies step away from that family, they can continue to have those supports in place for the parents and the child. It's also important to remember that there should be no meeting about me without me. And that really should be looked at for the parents and the child included when we're talking about services and supports to be put into place for the family. Everybody should understand the teaming process of CFT meetings and teaming meetings that include education and regional center. But also understand the integrated core practice model and how we should interact and support our children and families. So here, again, I just mentioned this, but making sure that the parents, child, and youth, they're a part of developing their plans and what services and supports are going to be important to help them to be successful in their program. Making sure that Regional Center is a partner at the table, as well as education, is important. And I believe that we saw that with some of the out-of-state work that we did in returning youth to California. Having all members of the team together, we could address the child's needs. And each partner has a different lens that they're looking at to best support the child. Talked about the education partners, and really this is about collaboration. No one member is more important. I would say the importance goes to the child and the family. They are the most important members sitting at the table, and we should be supporting them. And then I think with this one here, what comes to mind for me with some of the out-of-state work that we did of returning children to California is that while we had regional center, education folks, mental health, probation, child welfare folks sitting, I'm going to say sitting at the table, we were of course on Zoom meetings or phone calls. We did not have medical partners sitting at the table, and many of the youth that were returning did have some pretty significant medical issues. And so it is important to make sure that there is that coordination and making sure that the expertise is a part of the team in order to serve that child and that family's needs. So again, this information can be found in the 2083 MOU guidance. And I'm going to now turn it over to Richard.
Diana, thanks a ton. Wanted to spend just a couple minutes with you as we advance the slides here, just reconnecting the teaming processes to part 2 of your MOU, the integrated core practice model. So let's see, my slides are not advancing. Nancy, are we, one more.
Sorry. I'm a little bit, hold on.
23, I think.
There we go.
There we go. Thank you. So the MOU's primary intention is that it be a place where local partners commit to and align our values towards integration. And there's a fundamental theme of teaming and collaboration that pervades all of the processes and the values. And so here on the right, some of the key values or elements that are reflected within the state's integrated core practice model. And just want to remind people that this is the place where, from a behavioral standpoint, we reduce the conflict between team members. We align our focus around the youth needs rather than the public systems needs, where we balance the needs of the court or the needs of the provider vis-a-vis the needs of the youth and the family. So ICPM is really the anchor document to support teaming. Next slide. A quick reminder graphically, visually, to just remind that all phases of care captured within the integrated core practice model happen in a team environment. So when you think about an episode of care, when a young person comes into care, and we begin that engagement process, and we begin to think about what the team will look like and how it will function, right through the assessment, service planning and delivery, the monitoring and adapting of that plan, and the transition or aftercare planning processes. All of those happen in a team environment. So there's nothing for a young person in foster care, particularly a young person in placement who has almost universally complex needs. Nothing should happen absent the team environment, which is why this is such a critical concept to understand and to really bake into your MOU with as much meaning as possible. Next slide. To anchor that, we've just pulled in slides 25 and 26 here for your quick reference, just a quick look at 3 or 4 of the leadership behaviors from the integrated core practice model to just reconnect for just a moment and have you ponder on the relevance of this and the criticality of it. The authenticity that's needed at the leadership level within the interagency leadership team, at the practice level, of course, for teams, but also within the interagency placement committee process, and for basically every level of the organization that's part of this system of care. Next slide has 2 more practice behaviors lifted from the ICPM, so we'll give you just a second or 2 to ponder on those. With an invitation, of course, to go back to ICPM frequently as you're crafting your MOU and as your interagency leadership team process takes shape in terms of the teaming process and the collaboration that you need at that highest level. Really look for ways to establish yourself, to build yourselves on this core foundation of ICPM-based leadership behaviors that are contained within ICPM. And with that, I'll throw it to Ashley.
Sorry, Richard, you cut out at that last minute.
I think we're going over to Ashley.
Okay.
Next slide, please. Thanks, Nancy. In the MOU, there's a critical opportunity for the CANS to be the planning tool in the System of Care MOU. CANS is positioned as a perfect statewide communimetric tool, the device by which child and family serving partners can align their perspective with the families, especially for our children and youth in multiple services, and that often being the situation for children and youth in foster care. We hope to see in the local MOU some references to the CANS and what the local system partners will do or are doing to ensure that CANS is that communicational device and that partners have access. The local obligation is to ensure that all partners do have that access to the CANS. Next slide, please.
Is this the slide you're looking for, Ashley?
That's it, thank you.
Okay, good.
Our slide deck's just giving us a moment to all have a pause and breath, I guess.
Okay, that's good.
Here we can visualize where within the team and teaming meeting is everything from the last slide. So where is it happening? CFT team and team meeting is the vehicle for collaboration on assessments, case planning, and placement decisions in order to have that understanding of the assessment, integrate the family story, develop the shared vision, and support change management. Stay tuned. In just a few moments, we will hear from San Diego about their experience and how that happens, how all this can be done. Next slide, please.
So you'll see here in this often used graphic that you've seen before if you've been with us, that teaming is practical and ideological at all levels. From the first gold line, horizontal gold line, that's where the interagency leadership team, where your any advisory committees or executive advisory groups to the ILT function in terms of teaming, and it cascades right through management down to practice and into your contracted relationships with vendors, right? So teaming is universal, happens in all sectors, and this is just a nice way to kind of conceptualize the network, if you will, in terms of how we actionize teaming. It's just a construct until we actually walk the walk of collaboration and alignment. Wanted to call your attention to the fact that in the last few months, underneath some parallel technical assistance development, there are some tools that are available to local system of care implementers. So as you're thinking about how to implement teaming, whether that's child and family teaming or other forms of teaming, there are some tools that could be adapted at your local discretion. And we put a link in an upcoming slide here in just a second for you to access these tools that are posted on a CalSWEC website. But these are just fantastically powerful tools that could be used locally, again, to support your teaming effort. There's a tool that allows you to do some early multi-agency assessment. So from a system of care standpoint, that snapshot tool lets you do some local analysis about our readiness to do teaming in a really meaningful way. There's also an implementation guide and a template to support your implementation of teaming, and then a set of toolkits. And again, there's a link upcoming here momentarily that you'll be able to see. We can probably advance to the next slide, Nancy, and then just ponder kind of as we begin to transition and hear momentarily from San Diego on this, just some considerations for effectiveness overall to support the implementation. So as you take a look at those tools, or as you use other tools to implement a thoughtful, aligned, effective teaming on behalf of young people and families, think about the need for cross-training of all direct service staff in integrated core practice model and teaming. What does that mean? We need to understand what teaming means from each other's perspectives if we're going to be in alignment when we engage young people and their caregivers. We should be cross-training to one another's service protocols and processes. Some of you reflected that in chat earlier in response to one of the poll questions. So major acknowledgements and celebration. If you're starting some of that work, that's critical stuff. We know that that 2083 invites in a number of places the exploration around a common or singular needs and services plan or a singular treatment plan. That's a very heavy lift. I wouldn't get stuck on that in terms of a demand, because there's a lot of prescriptiveness in the various funding streams across the state that require uniqueness to those needs and services plans. So don't let that stop you at this point. Just keep moving towards alignment of a unified process. And then down the road, as a team, collectively as a state, we can address the imperative around a singular uniform plan. But that's a heavy lift that I wouldn't let get in the way of other efforts to just align the practices, if you will. Don't worry about the forms at this juncture, I guess is what we're suggesting. And finally, the tools that we referenced in a prior slide, I actually think it was just the slide prior to this that's coming up here on the resource slide that Olivia will talk to us about. You'll see, I would just encourage you to look for ways to adapt and leverage those implementation practice tools. And with that, I'll kick it over, I think, to Olivia.
Thank you so much, Richard. Thanks everyone for your attention in these past few slides. The following 4 slides are actually resources that you have available for different types of things, such as the toolkits for system of care, foster care education, the CASWEC, also known as the California Social Work Education Center. And can we please advance to the next slide? We also have links on CDSS teaming primers, the California Health and Human Services System of Care webpage, and the MOU guidance informational notice for AB 2083. Next page, please. And another additional AB 2083 MOU guidance link that would be helpful. One more page. And of course, the recommendations to the legislature on placement and services gaps. There's also a link for that here, so you can access and read through that. And now I actually would like to welcome everyone. If we can please advance to the next slide. Oh, I'm so sorry. Before then, I thought we would do Q&A. So I'm not sure if this is a good moment to pause and answer some questions. Otherwise, we can go ahead and welcome San Diego with their presentation.
Sure, there is. Sorry, I was just going to mention there are some questions in the chat, unless somebody, a panelist, sorry if I interrupted another panelist.
Yeah, no worries. This is Shelley. I see a lot of the questions are related to the communication between child welfare and behavioral health and partners with the CANs and all of those. I think they'll be addressed mostly through the slide deck, so that might be the best way to proceed. Do you want us to start? Okay. All right, Jenny, you going to kick us off?
I'll kick everybody off.
Thank you.
Thanks, Shelley. Good morning, and thank you, System of Care Technical Assistance Team, for inviting us back to share our children's system of care work and teaming efforts in pursuit of a single unified teaming process to maximize planning and family engagement for all youth in care and their families in San Diego. And to our state and county partners that are on the call this morning and coming together to collectively accelerate the system of care work, great morning to you. We are delighted to return and present on child and family teaming and service planning, and hope that through this sharing, you are able to grow from our lessons learned and take away ideas for your practices for successes, and to continue enhancing what you already are doing and doing best. My name is Jenny Rodriguez, and I am a policy analyst for the County of San Diego Child Welfare Services and the 2083 Children's System of Care Lead. It's with excitement that I begin this presentation and briefly turn it over to the rest of the team today for our introductions, or for their introductions.
Here's Shelley Paul, Child Welfare Services. I have a new title. I can't. I'm over program policy and support. Thank you.
Hi, Eileen Quinn-O'Malley with Behavioral Health Services. I'm the Behavioral Health Program Coordinator, overseeing mental health contracts that support foster youth at various levels of care.
And I'm Laura McLaren. I'm Senior Director over the Child and Family Team Meeting Facilitation Program, as well as other things at Fred Finch Youth and Family Services. Happy to be here. Thank you.
Thank you, Shelley, Eileen, and Laura. In partnership with the team today, we are excited to share what engagement in child and family teaming looks like in San Diego, and the various ways we collaborate from within the child and family team and with other systems for assessment, service planning, delivery, coordination, care management, monitoring, and adapting services and transitioning. Next slide, please. Thank you, Nancy. This presentation is also aligned and supports the Live Well San Diego vision. And Live Well San Diego is our county's vision for a region that is building better health, living safely, and thriving. There is value in taking a moment to share this, and that's because it aligns the efforts of individuals, organizations, and government to help all 3.3 million San Diego County residents live well, and it involves everyone. And when I say everyone, we're talking healthcare providers, community, faith-based organizations, businesses, school districts, and other jurisdictions, including cities, tribal governments, and military or veterans organizations. Live Well San Diego recognizes the importance and value of aligned partnerships, and that only through a collective effort in which all of us work together toward a shared purpose can really meaningful change be achieved in a region as large and diverse as San Diego County. Live Well San Diego also provides a foundation for teaming and engagement, and uniquely positions us to enhance upon teaming and partnerships with all systems and at all staff levels, and provides for highly collaborative interactions to move the needle further with our collective outcomes with our children's system of care work, aimed at providing highly coordinated, integrated, and innovative services and supports to children and youth. Next slide, please. Thank you. So San Diego County's children's system of care work is not viewed as a silo effort and cannot be possible without strong collaborations and those robust discussions among teams of committed and dedicated partners, all coming together to do the right thing for children and families. Our Live Well San Diego vision has helped lay that foundation for participatory process to engage populations and systems, and provides various pathways for improved outcomes for all our residents. Our partnerships in our children's system of care work involve both traditional, non-traditional, established, and new partnerships. Our system of care partnership extends from the county child welfare, behavioral health, juvenile justice systems, to our partners with the County Office of Education, special education local plan areas, and regional center, and further on to the partnerships and voice of our juvenile court system, court-appointed special advocates, and our tribal nations. Together, we all share in the responsibility of our collective children and youth. And with San Diego being the largest region with the highest number of tribal nations, 18 in total, we actively pursue and integrate partnerships with numerous consortiums to ensure tribal voice and representation is integrated into practice, policy, teaming, and vision. But it's important to share that we are not an exclusive group of system of care partners. We also recently welcomed San Diego Department of Rehabilitation as one of our newest partners to join the San Diego System of Care effort, and we are excited to grow this partnership. We continue to forge new and diverse relationships and move forward in our commitment to our children and youth and their families. When engaging and teaming with partners, we take the time to learn about their systems, their values, identify common ground and intersecting pathways that provide for those opportunities for integration of services and leveraging of resources and supports for youth and families. Next slide, please. Thank you, Nancy. As we considered ways to move deeper into our children and system of care work, we took a moment to step back and reflect on our relationships and engagement with all partners. And we began scaffolding on earlier successes and teaming adventures. We borrowed on the early partnership and collaboration successes of our implementation of the integrated core practice model and the pathways to wellbeing rollout in our county. We reflected on what we were doing well, and that was engagement. It was teaming. When we began our work implementing the core practice model, CCR, and other large system initiatives, our county made a commitment to ensure all impacted system partners were at the table early, involved in regular leadership and implementation meetings. And this process ensured that all partners were informed, involved, and engaged in participatory process. It also improved relationships between system partners and led to cross-system education and trainings, meaning our systems understood each other better. So these early efforts to collaborate on system reform have made our 2083 endeavors much easier to achieve. Even now, when we have system-wide issues to address, or even when we have child, youth, family-specific need, we ensure all partners are invited, engaged, and involved in teaming and planning. The success of our CFT meetings are an outcomes of our early teaming efforts. And this cleared a pathway for a successful CANS collaboration and utilization for youth interacting with our child welfare, behavioral health, and juvenile justice systems. As you hear in the next slides, CANS in San Diego is seen as a communal entry to care and is completed in a way that invites other systems to come together, to engage and team and collaborate and have a rich dialogue on how to bring services to a child and not have them go through other doors, thus supporting the no wrong door policy. This is just an example of where and when high-level collaborations can be observed and illustrates how agencies such as County Office of Education and Regional Center are engaged and teamed to determine all needs of the child is being met. Partners within our communities to include County Office of Education, Regional Center, court systems, tribal nations, foster parent associations, and various county departments were informed and trained on the CANS and the sharing of CANS within allowable teaming platforms. And on a child welfare perspective, we paused and thought about how teaming goes beyond the walls of child welfare services. We recognized how teaming and engagement behaviors are universal and is practiced and valued across sectors and with other system partners, such as within the Office of Education. And Renzo briefly spoke to this about meeting and teaming to discuss individualized education plans, or even teamings around student support teams and 504 meeting plans. And with our regional center partners, meetings and teaming around individualized program planning, individualized family service plan meetings. What has been very helpful for us is that we have Regional Center and County Office of Education liaisons that help ensure this engagement and teaming from these systems when applicable. So for us in San Diego, our next big lift is finding pathways and to continue finding pathways to integrate these individual system-specific meetings when possible into one teaming process to better coordinate care and reduce the demand on the youth and family for meetings. We also continue to explore ways on when the team of interacting partners can all be at the table with the family, and when a CFT meeting can begin and roll into an IEP meeting or an IPP meeting. So that's the pursuit we're currently on, is really what are those pathways that make this possible? And you'll hear as we move through these slides, you'll hear references to last month's webinar and a lot of the sharing we did around the teaming, around interagency leadership teams, IPCs, MDTs, barrier busters. So I just set the stage for how we turn all this into practice, and we'll now hand this off to Shelley for further examples of our engagement in teaming.
Thanks so much, Jenny. If you wouldn't mind advancing to the next slide, that would be great. So my name is Shelley Paul. I didn't introduce myself very well. I apologize. I've been with Child Welfare Services in San Diego for 22 years, and I was very fortunate to be the policy lead since 2018 for mental health, which included child and family teaming and the CANS implementation and rollout. I just want to share, if you guys have not Googled the California Integrated Core Practice Model Manual, please do so. This truly is a foundational piece of literature that reads in a way that really reinforces our heart and mind about the practice of serving others. And it really supports how we can do business together through partnership with all of our system partners to best meet the needs of families. It's really incredible. We know that we're touching other families. Child welfare, 80% of our kids touch behavioral health services, and many of our families touch probation and regional center, and obviously almost all of our kids touch the educational system. So it really helps us formulate a vision about working together that best meets the needs of the children and families we serve. And that leads to best outcomes. Just a few key principles from this manual that we use in our practice. Children, youth, and family are the experts. Number one, the child and family team makes the voice of the family as loud as the voice of all of the system partners. It's critical that family's voice and choice is as strong as ours. Historically, I told you I've been here 22 years. 22 years ago, our voice was real loud, like with a megaphone loud, and the families were talking really low, and we were leaning down and listening, hopefully, if we were good social workers, right? But over the last 22 years, and especially in the last 10 years, we've really made sure that the family voice is as loud as ours. In child welfare, the moment when we decide to remove a child, our voice gets louder than the families for the most part, right? 99% of the time. And in order to bring our volume back to the same place, we need to come together in the child and family team meeting. They need to have their natural supports present, and they need to have a voice that's as loud as ours. Next slide, please, Nancy. I just wanted to share just for a quick minute, because this is always of interest to the other counties. But in San Diego, we decided, gosh, it's coming on 5 years ago now, that we would like to have a joint child and family team facilitation contract. So the big agencies, child welfare, behavioral health, and probation, came together with contracts to create a joint contract. So we put out a request for proposal, we put out the statement of work, and then that went out for bid, a competitive process. It's really been a huge shift in how we've done business, and it's created an integrated referral form. So any provider, therapist, social worker, probation officer, DSEP, our developmental screening and enhancement program, wraparound, we all use the same referral form, and it comes through to our centralized provider. Just to be clear, they do all of our open case child and family team meetings. And we still do ER child and family team meetings internally. Hopefully we can expand the contract in the future. But so anybody that has an open case, that's who we're impacting the most with our families, right? They're going to have that completely neutral facilitator through Fred Finch. It's made a huge difference. We've been doing surveys in San Diego for child and family teams for a long time, years, and the survey feedback has improved since we've started with the neutral facilitator. Families definitely felt like if it was child welfare facilitator or a BHS, a therapist facilitator or a DSEP facilitator, they felt like that facilitator was pushing the agenda of the agency. Now, we didn't always feel like that as social workers. I'd be like, oh, why are you like supporting the family so much? Back the agency up, right? But to the family, it really felt like, because they were able to kind of explain our system and explain our processes, it felt like they were aligned with us. So just so you know, neutral facilitation, the state really recommends it, and we have found that to be very beneficial. It was mentioned through Richard that teaming is different than the meeting, right? So the team always exists. In between the meetings, that communication needs to be fluid. We do formal child and family team meetings. We'll go through the 14 reasons we hold those, but we also do informal conversations and communication throughout the life of the case. The meeting itself is that facilitated process designed to produce the transparent plan for safety, placement, and services. And I just want to say, I think one of the greatest things about the CFT action plan is that the families can hold us accountable, right? Agencies are really good at holding families accountable, but when we have that clear plan, the social worker will do this, the therapist will do this, mom will do this, auntie will do this. It can be that mutual accountability. It decreases the power differential, which is what we need. Next slide, please, Nancy. So I mentioned there's 14 reasons to hold a child and family team. Some of these are reasons through CDSS all county letters. Some of them are reasons that we've decided. Some of them are best practice reasons. But these are the 14 reasons that are listed on our referral form. And we do check every single reason that we need to have a meeting. We have found that it's best for families, for the most part, there's obviously caveats for this, to have a 2.5 hour meeting versus 1 hour and 15-minute meetings. This was especially true before the pandemic, when people were having to travel to meetings and having to really rearrange their work schedules and all of those things. And our provider lead, Laura McLaren, is going to talk about some of those benefits of the pandemic and some of the worries as well in a little bit. But just wanted to share, by taking this holistic approach to having these reasons, we can really capture, we don't miss reasons to have a CFT. So then 2 weeks later, we're like, oh, we forgot to do this. So we have to do it. What happens when we have the right partners at the table and we're talking about these topics is it reduces the family's trauma by having to retell their story again and again. It really creates that joint decision making so we can present to the family all the options that we're recommending, and then they can really choose what's best for them. And it ensures that they get the best services to meet their needs. Next slide, please. And I'm going to hand it off to Laura.
Hi, everyone. I'm going to spend a couple slides just talking more about child and family team meeting, getting the right members at the table. So far this fiscal year, July to December, the program has done, let me find it, 1,923 meetings for child welfare service, probation, behavioral health services. We also do serve youth that are in San Diego County that aren't officially system involved, yet may need the model of a child and family team meeting, which is bringing all the members together, the family, the youth, formal supports, and natural supports. So we definitely have mandated members that we need to have at every child and family team meeting. Some of those are listed on your screen. We definitely need the child or the youth there, the non-minor dependent, of course. As Shelley mentioned before, there's caveats to those. If we're really discussing sensitive material, or potentially we have really some things to discuss with a parent or a caregiver, and we feel like we need a portion of the meeting without the youth, then we will do that. Again, it's really based on the needs and what needs to be brought up. There's also mandated members like the social worker, probation officer, supervisor, and other tribal partners. I'm going to share a success story in the next slide about a case with tribal partners that were part of our process that really helped it, as well as the professionals, the mental health therapists, the CASA supervisor, school personnel, regional center. Our real philosophy is the more people we can get at the table, the better. The more thorough child and family team meeting we're going to have, and a huge push of our contract, which I really love because I'm from the nonprofit world, been in about 15 years or more than, is literally natural supports. Who else can we bring to the table? The professionals are amazing. You each bring your strengths. And who else does the family or the youth need in the room that's going to be with them beyond the paid people? I did wraparound for over 7 years, sustainability. We need those natural supports. And this was a paradigm shift in San Diego County, and I love to see that we're moving through it, that now I'm seeing system partners be like, yes, let's have the nanny, let's have the aunt, let's have this person at the table, versus like, what do you mean the nanny's going to be there? Like, what? There's no place for a nanny. And we have gone from CFTs with the social worker, maybe the youth, maybe the wraparound staff, to literally 15 to 20 people is our average CFT right now. Literally, if we have a small CFT or 5 or 6, because sometimes it's a post-adoption one, but even then we're like, who else needs to be at the table? So definitely no wrong door policy. How can we get everyone who is important to this youth and family? And there are lists on your screen. I'll show the referral slide. So if you can go to next screen, please. Oh, and I did forget to mention attorneys. Someone wrote that in the chat, and I'll get to that in the next slide. Attorneys are definitely part of the process. And one interesting trend that COVID is, we have way more attorneys come to the meetings, which are good. And it can also pose some challenges, but I'll get to this. Here's our referral form. The amazing thing about this referral form is we have updated it and customized it along the journey of our CFT process, meaning the second page, and I know it's a little small, we can email out to everybody if they want a copy of the form. We have set categories on the back page that encourages all that member participation. And we've got an added additional categories because we wanted to increase the membership at the table. It's really there to get the diversity of the team. As you can see, the first page lists the reasons for the referral. My favorite thing I like to do, I go out and present to the CASAs and foster parents and school systems, is my favorite reason for a CFT is people can also request it. Any member of the child and family team meeting can request it. And we also encourage all our providers and our system partners in San Diego, please, the more information you can put on this form, the better. We are there to be neutral. We rely on talking with each person before the CFT meeting. That is also a pre-contract, that's a contractual obligation before every meeting. We talk with every member. We say, hi, this is the reason for the CFT. And we go over the needs, and I'll expand on that more the next slide. We include cultural considerations. Again, we include the voice of the experts, like the attorneys, as you can see on the, well, it's small, but on the bottom of the second page, there's a prompt to say who is the minors counsel, and we notify them at the meeting. And again, we ask the family though, and everyone else, who else isn't on this form, who needs to be there that you want me to contact. And we even bring in our knowledge potentially of who could additionally be invited. For instance, if there's an educational liaison and the child is with child welfare, where it's like, hey, if the school person's going to come, should the educational liaison come? So this is just a capsulation of the referral form. Nancy, if you can do next slide, please. So engagement strategies, and I hinted on this, but a huge thing of what we do is we call every member before the child and family team meeting, and we talk about what are agenda topics that we need to talk about. We talk about the ones that are on the referral form, whether it's, okay, we need to talk about reason for removal, whether we need to talk about this youth is in a STRTP, and we're going to be evaluating treatment goals. We also, if CANS is a conversation, okay, we're going to do our first assessment CANS, and what does that look like? We bring in cultural considerations. That tribal case I said, we've done, we did 4 child and family team meetings for youth that were part of a tribe in San Diego County. We made a point to hold the CFTs on the reservation. That was extremely important to the family. It meant an over 2.5-hour drive for all the members of the CFT. And that was the social worker, the supervisor, the facilitators, KC Family Programs was involved, as well as DSEP. Yet we all felt it was so important in order for this youth and their family to have all their natural supports. We met on the reservation. We had child and family team meetings that started with 14 people and now continue with over 19 people. And the family has gone from being a little bit more closed off to speaking more, talking more, mom sharing more about her services because it's in her community where she feels the most supported. We had another case, it was an adoptions case. Unfortunately, this youth was just switching between placements and placements and placements. And we invited, because again, we do the repeat CFTs, we invited the previous adoptions workers to that CFT, along with, we had the CASA there, we had the CASA supervisor there, we had the school personnel there, multiple, and we also had an educational liaison. So that's our example of how, because we are the one provider, we see the first episode, we see the second episode, we're able to we do a team check. So not only when we're calling each member before our child and family team meeting, are we asking them, hey, these are the people who's there. We're asking them who else they need to be there. We're also at each child and family team meeting doing a team summary. If we didn't have a natural support in the room and we had 20 professionals, which again is wonderful and amazing, who else needed to be there? And I know the chat's going crazy, so that's great. Shelley, thanks for manning it. And if you need me to speak to anything, let me know, or I'll pause in a second and someone can interrupt me. Who else needs to be there, especially natural supports? Again, I'm a big push for that. If we didn't have one natural support and 20, when we have the next CFT in a month or 2 or a couple months, or even when do we need the next one, who else needs to be there? We give each family and parent the link to the state brochures for child and family team meetings. And really, we have different scripts. If it's a first child and family team meeting, we're going to talk more about the structure. We always start with group agreements. We go into what's working well. We talk about concerns, and then we create our action plan. So usually for our caregivers and our kids, if it's their first CFT, we spend more time explaining the process. But if it's their 5th or 8th, it's comfortable for them because they know what to expect. And we do customize it. We do have some parents who are like, hey, I don't want to go to strength. I want to know what I need to do to get my kid back tomorrow. And we can customize it, yet we like to follow the structure because that shows consistency. And like Shelley and Jenny said earlier, it helps keep all our system partners accountable as well. And CANS is really going to be expanded on. Eileen's going to get to that. CANS is a huge part of this conversation as well. We have visuals that we use to describe it. It's really conveyed a more shared sense of treatment planning and what we're working on. The social workers use it to build the case plan. If we have a therapist involved, they're using it to build their treatment plan. And then families then get a sense of, okay, I'm a mother, I'm a dad, I have substance use, and this is an area of need, and then this is a strength as well. Want me to keep going? Yeah, Shelley? I know there's a lot of chat going on. Okay, maybe we'll get to all the questions at the end, but this is great, thank you. If you can go to next slide, Nancy. I did want to say how many formals and natural supports we had real quick. So in fiscal year 19-20, so that's from July to June, we had 3,611 natural supports at our CFT meeting, and then 16,344 formal supports. Average right now with COVID, it's taking us about 8 days from receiving the referral form and scheduling. So scheduling has been way easier. And we have about 99% of our meetings happen within 5 days of the CFT meeting due date. Those are some outcomes I wanted to share. And that has been the interesting switch with COVID. We've had increased attendance. I joke, but I don't. Lawyers are attending way more frequently. We do go over with lawyers if we send them the policy. If they are there, they're there as a natural support. They're not there at their official capacity. So we don't want them using the child and family team meeting as an investigation. And they have to notify their other members, their other attorneys, if they are going to be present. And for the most part, attorneys are able, and they're a crucial part. And again, it's more people being on the same page at the same time that supports the family and the youth. Again, we've had more natural supports attend since we've gone virtual. We've had more people attend, I think, because instead of having to drive here or I have to go to a child welfare office, we use virtual platforms. We use Teams, we use Zoom, and we also use the phone. We have an app called Conference Now that allows for an unlimited number of people to be on the phone. And we've really seen some people, some parents and caregivers prefer the phone. Therefore, I'm not on video. I'm not on display. Maybe I already feel enough that I'm on display. And the phone allows for a bit more transparency and for me to tell what I'm doing. Also, facilitators have a bit more authority over the phone to enforce those group agreements potentially. Even though we had one youth, he kept interrupting and yelling over everybody. We kept muting him, and then he figured out if he hung up, he could like bypass the whole system. So they are very savvy. And the wonderful thing about system, again, coordination, since we went virtual, the program got more funded through VHS and the CARES Act to get more Zoom licenses. And we are increasing our use of video platforms, which is good, because I think there are some conversations that used to happen in person that are now on phone, that it could be beneficial. Again, video, like I can't see anybody, right? I see there's 167 people, but I see a PowerPoint. There's some conversations that need to be have on video or can be helped to have for the body language. And we really adapt and we give families the choice of what we're doing. And that's a bit about CFTs. I know I covered a lot. It's, yeah. So I'll pass it over to Eileen, and then we're definitely going to leave time at the end for questions, and she's going to elaborate on CANS.
Thanks. I think I'm actually going to
Oh, sorry.
No worries. It's all good. Can you go back one, please, Nancy? That's so, maybe my slide deck's out of order on this one. Okay, so go forward one. I'm sorry. Thank you. So you guys talked a lot about transparent communication between the partners and with the family. It's so critical. And the way that we're really getting to that, and I talked to you guys about the family's voice being as loud as ours and making sure that we're on the same page, is through having these open communication and open conversations. And I do want to say that this was difficult in the beginning. Behavioral health, therapists typically don't say, damn, you got a lot going on with your family. I got a lot of worries, right? And list them all out. In child welfare, we do. We're like, oh my gosh, I'm worried about 10 things. These are the 10 things, right? It's just a different feel. therapists don't want to overwhelm the family. We want the family to know everything we're worried about so we can make a plan together. So Eileen and I have spent a ton of time. We've done over 60 trainings a year, I feel like, for the last 3 years, making sure that people understand the intention. Families know what's going on with families, right? It's really not a secret to them. So it's okay to bring those things forward. And we do it in a caring way as a team to support them. We talk about their strengths. We talk about their needs. And Eileen's going to talk a lot about this, some suggestions for information sharing. I just want to share with you guys, San Diego uses these ACLs that I've listed for the child and family team and for the CANs to communicate transparently between the system partners. We've never had an issue with communication between system partners. There hasn't been a time that somebody was like, a family member thought we shouldn't have shared something, because it's all discussed together in the child and family team meeting. The parent is signing a consent at the beginning of the meeting. That is our standard practice. The contractor holds those consents and, you know, emails them to the parents afterwards, because obviously that signature is happening virtually at this point. We're making sure that the family knows that the purpose of all of us being together and sharing the information is to have the best outcomes for their family. So that has never been an issue. We do use the CANS family letter, and we're happy to share that with you. I know a lot of you guys are hoping that we'll share our policies and our tools, and we are happy to do that. Please email me. I don't want to have to go through this whole chat box and email you guys and find all your emails. So if you need that information, feel free to email me. So I hope that's helpful. Next slide, please, Nancy. So we talked a lot about this one CANS, and the state talks about it a lot. And I'm just going to, you know, call you out, state, because you do want us to use one CANS, but you require us to use different tools and upload it to different systems. So for the most part, the tool is the same, right? The 450 items, the caregiver needs and services, they're the same. Behavioral health has some additional modules. So they do the ACEs module if they hit triggers, adjustment to trauma, which obviously they're typically hitting with our kids. They also have the substance abuse module and the sexual orientation, right, Eileen?
Yes.
SOGI. Thank you.
Criminal justice. Mm-hmm.
And a criminal justice module. Thank you. So they have a few extra modules. So a few things I want to say. What typically happens is we come into our child and family team meeting, we create that initial CANS together with all of the system partners and the family and all of their extended network, their natural supports. And then we share that. We share it with the court. We actually attach our child welfare CANS to the court, to our court reports. By the way, we were worried these were going to be litigated. That has never come to fruition. And I quickly realized it's the best. If I had to testify about a CANS, why did you pick a 2 for depression? My response would be, that's what the team agreed on, right? I mean, it isn't my job as the social worker to determine the CANS. It's a group decision-making. It's probably one of the reasons it's never been litigated. As an aside, complaints about our court reports have decreased significantly since we started using the CANS. Families feel they understand more. We're being more transparent. They're part of the process. They understand their case plan. They're getting into their services quicker. We're reunifying quicker, friends. It's amazing. These are unexpected outcomes of the CANS. But I digress, because this is what I get excited about. So yes, our CANS are very similar. We complete that child welfare CANS. We give it to our other system partners so they can use it as part of their assessment. If the therapist creates their own CANS, which they do because their CANS is different than ours and they upload it into a different system, and there's changes. So let's say we put a 1 for depression because we know the child's really sad and we're worried about that. And the therapist goes, no, that's actually a 2 now. They send their version back to us in child welfare. The social worker compares them, and then they notify the child and family team members, hey, remember we were worried about depression for Susie? The therapist agrees the child is going to have ongoing therapy. Or, hey, we were worried about adjustment for trauma, so we referred Susie to therapist. Therapist agrees. She's going to have ongoing services. So that's that communication, that teaming across the system partners and the family and the natural supports that we're just want to really reinforce. That communication has to happen in between the meetings, right? And it's both ways, because then we can check in on how things are going. The most important thing is the worker's comfort with that presentation in the child and family team meeting, and that happens over time and through training. And I think I mentioned initially the system partners needed to adjust, but it's really working. We're seeing huge differences in the successful outcomes for families. Eileen, did I miss anything on that slide? Eileen normally does this one and she does amazing.
No, you covered it quite well. I just think that, it's just the ongoing messaging that it is one CANS. And so, the communication is key to this. And so it's, we've been doing this for 3 years, like Shelley said, and we still have to remessage this over and over. So it's an important component, and we're hoping that soon one database will be developed. That's the dream. So until that time, we keep communicating.
Yes, we would love for the state to give us a universal form and system. That would be amazing. Next slide, please, Nancy. So I just want to let you guys know, part of the way we sold this to our team, our social workers, was that we took stuff away. So, okay, yes, you got to do the CANs, you're going to learn a new system. You have to get trained and certified on this every year, right? We've never certified social workers on things before. But you don't have to do the SDM, CSNA and the FSNA, Family Strengths and Needs Assessment, and the Child Strengths and Needs Assessment anymore. You don't have to do the old mental health screening. This is kind of a universal tool. Maybe someday it'll be our level of care tool too, right? This is an amazing holistic look at the child, and we're really seeing great outcomes. So I just want to remind you guys, CANS can be the mental health screening. It's those first 9 items per ACL 1881. If the child scores a 1, 2, or 3 on those first 9 items, which is called the behavioral emotional needs domain for the 6 to 21-year-olds, or it's called the challenges for the little kids. So if they score a 1, 2, or a 3, we refer them for an assessment. Next slide, please, Nancy. In San Diego, we were originally sending them for a mental health assessment if they scored a 1, but we soon realized if a child was in an open child welfare case and had trauma, the therapist was going to say they needed more therapy, which makes sense in hindsight. So we actually eliminated the mental health assessment, and we just refer straight to therapy if they have a 1, 2, or a 3 on those 9 items. We've had some really good outcomes about this. I'm going to be honest with you. Before we started, I was worried we were going to over-refer kids way too much. We went from referring 30% of kids with our old strengths and difficulty questionnaire to 80% of our kids with the CANS. But actually what we found is kids are doing much better. They're getting to resolve and process those worries and the trauma at a lower level when they're less dysregulated and less impacted. And because of that, they don't become more dysregulated and more impacted, which sometimes can actually lead to difficulties with reunification when the child themselves has difficulties with that. Next slide, please. And then I just wanted to link it up for you. So I think this is one of the parts that the social workers have made the most progress with and were the most resistant to in the beginning in child welfare. So any score of a 2 or a 3 on the needs domains is going to have an action plan item. And somebody asked who does our action plan. So the CFT facilitator is the one logging. They're writing what's working well, the worries, and the action steps. And they're facilitating that conversation. The assigned social worker, child welfare social worker, or the therapist, if it's a BHS one, kind of holds that conversation around the CANs. And we kind of rule out all the zeros, and then we talk for a minute about the 1s, 2s, and 3s. These conversations take an average of 15 to 20 minutes per child, much quicker for little kids. The little kid one goes quicker, lots of zeros typically. So people worry that this is going to really increase the length of the child and family team meeting, but it doesn't impact it that much. And the benefit we get out of slowing down and helping the families understand all those dots that are connecting to their case plan is worth every second we spend on it. So anything that's scored a 2 or 3 as a need is going to be in the action plan and maybe in the case plan. And I want to give you a quick example. So we had a 10-year-old who was really having a hard time sleeping after he was removed from his mom and placed with his auntie. And in the child and family team meeting, we asked him why he was having a hard time sleeping. And he said that he was worried about his mom because he only got to talk to her a couple times a week. So everyone made an agreement that mom would call him at 7 o'clock at night and they would chat for 5 to 10 minutes. And that resolved his sleep issues. So we didn't make it part of the case plan, but we did talk about it in the court report. So the judge and the attorney would know This issue came up, we made a plan as a team and it resolved it. If he had scored a 1 on one of those first 9 items and he was being referred to therapy, that would be part of the case plan, right? And this gets confusing for parents, so we've really been navigating it a lot. But if a parent, let's say they scored a 2 for one of their needs, perhaps housing, instability, you know, depending on where we were at the case plan, that might not be part of the case plan per se, but it would definitely be part of the action plan that we're going to make them referrals to services. We're going to make a referral to our housing navigator. All of these things we're going to do. If we were closer to reunification, it might become part of the case plan. Anyway, just a quick dirty example. Down in quick example. Please don't tell me about how important housing is, because I totally agree. I'm just trying to think of an example that's less exciting than mental health. Next slide, please. And I'm going to hand it over to Eileen.
All right, thanks, Shelley. Okay, so I think Shelley outlined really nicely kind of year 1 implementation and kind of the task we were given, which is, you know, the training and messaging and making sure everyone understood the tool. So after year 1 rollout, year 2 provided a lot of great opportunities for our Children, Youth, Family System of Care Outcomes Committee to identify and develop resources that would enhance CAN sharing and integrate results when working with families. Just for a bit of context, our Outcomes Subcommittee is part of our larger CYF System of Care Council. And in that System of Care Council, we have representatives from the public sector, including behavioral health, child welfare, public safety, public health. Then we also have the educational sector, including special ed, regular ed, private sector, including regional center, fee for service, our Alcohol and Drug Service Providers Association, managed care plans, and then the family and youth sector. So in our outcome subcommittee, we have representatives from every sector. So it's great because the input that we received when developing the tools came from the perspectives of all these partners. So with that said, I'll move forward and I will share some of the tools and resources we've developed for our San Diego system of care. So the first one, and these are, I'm just going to list them, and then the next slides will have some visuals. So there's the CANS assessment summary, which has definitions. We have a graphic report, which has social determinants of health linked to CANS items. And so it'll make a lot more sense when we walk through that. And then we developed a crosswalk for the ACEs to the CANS trauma module, and then also strengths mapping in our client plan. So we'll go to the next slide. Okay, so this is a visual of our CANS assessment summary. It's a small snapshot, but I just wanted to highlight what this is that once the CANS results are integrated or entered into our local database, the report then is generated and identifies the strengths and then the actionable and immediate needs of the youth and family. You could see that the report's very straightforward. And it's really helpful when sharing with families. Instead of, the tool can be very busy when you look at the CANS tool. So this just highlights immediately what are the strengths that are going to be centerpiece and well developed, and then what are the needs we need to focus on. As a side note, I definitely want to give credit where credit's due. So San Bernardino, our neighbor, has been so helpful when we did our rollout. And so many of the resources that they developed was definitely a template for San Diego County. So I want to let you know, sharing resources and tools is so valuable. So for this assessment summary, we have our BHS providers share it in different venues, but the first is to share it with families and youth. The next is that we really encourage our providers to bring it to CFT meetings. So when CWS is finalizing their CANs and ensuring that we have one CANs, this is a great report that, you know, a provider can just reference quite quickly and just, you know, identify the needs on here. And then we'll move to the next slide. And I just wanted to highlight this as well. So we also, in this report, we have the definitions for the items that have been identified in the report. And so these definitions can then be a reference for families, and even in the child and family team meeting, if people say, well, what does anxiety mean? And so if that was something that was identified as a need, these definitions are very straightforward. And I will say in our outcomes subcommittee, our family and youth partners were really instrumental in developing these definitions to ensure that they mirrored with the Parade Foundation, as well as language that families could understand and would have some meaning for them. So that's the first tool that's been developed. We'll go to the next slide. So this is our ACEs CANS crosswalk. And so this was developed for BHS clinicians just to heighten awareness that the CANS trauma module does assist in identifying ACEs for CANS. And we identify this as a need because in working with Shelley so closely, I noticed that she always referenced the trauma module as the ACEs module. So I then quickly realized that we have to then kind of get up to speed and having our clinicians, our BHS providers, understand that indeed when they are completing the trauma module, if it's triggered from that adjustment to trauma item, that they then, when they complete this module, are looking at these ACEs questions. So this is just a resource for them. We also, what we'd like to do as well is I think this year, another goal of ours is to put the positive childhood experiences on the back side of this crosswalk. And we'd like to list out those positive childhood experiences and then map it over to the strengths in the CANS. So we're just really trying to be quite creative in ensuring that, all of these initiatives that are coming down the pike, we're providing resources for our system of care and understanding what they are completing. And then the next slide is just the continuation of this because we couldn't fit it all on one slide, it'd be too small. So if we go to the next slide, you'll see that the rest of it. So then we'll move to the next slide. So what this is, it looks a little busy when you first see it, but so one of the priorities in our outcomes subcommittee was to establish a method for identifying needs, for measuring social determinants, because we wanted to see, where the needs were in specific social determinants, because we know that this has such a high impact on mental health of youth and families. And so our starting point was to identify CANS items that mapped really nicely over to some of these social determinants. And I want to enlarge the slide I have because I know it's small and the graph is hard to see. And we can definitely email out, the actual graph itself. So in the second kind of green box, this social determinant that we're looking at is community, and the two CANS items leverage is one is living situation, which is a need, and then the other is community life, which is a strength. And so the first blue graph is the need of living situation. And so for needs, we want to see, when they discharge from a program, for that result to go down. And then for community life, that's a strength. And so, it started a little bit lower and it looks like those strengths became more centerpiece or well-developed. And then we'll go to the next slide. It's just a continuation. And I'd like to highlight just another social determinant that we look at as well. So thank you. So this is the continuation. And so another, social determinant that's really important to look at is social. And so the CANS items that we leverage from here, I have to enlarge my screen again because it's so small. So we have needs and strengths here. And so the needs that we identify is family and social functioning. Strengths include family strengths, interpersonal strengths, and natural support strengths. And I really like this one because, a key part in what we're doing when we're in CFT meetings, when we're working with youth in therapy, we want to develop more strengths because we know that this is going to be the key for sustainability for them to, move on and continue, with improving many factors in their life. So the strengths are important for us to look at. And, just again, the integration, like Shelley said, we integrate the CANS results into the client plan. So whatever needs are highlighted, we want to integrate that into the client plan to work on. And then for CWS, for the case plan. So our case plans and client plans are, looking similar to, because we're focusing on the same needs and supporting the family. So, we don't have the therapist working on something that's, left field. We're all looking at the same thing to support the family. All right, and then the very last slide here is just to highlight. So we had a provider who created this other mapping for us. And so in our client plan, we have many, many applied strengths that are listed. And so what the provider did, they took the strengths from the CANs and crosswalked it over to the strengths identified in the client plan. And again, because we just want to highlight that, these strengths are really important to look at. And one of the goals this year is to ensure that, one of the goals in or objectives in the client plan is strength-based. And so, increasing pro-social activities, making sure there's linkage to something in the community that is sustainable after treatment ends. So that wraps it up for some of the resources that I wanted to share. And sharing the integration of the CANS data for our system of care.
Thank you so much. Next slide, I think that might be our last slide, is our little YouTube. Yes. So this is, I did verify this will be attached to part of the slide deck that comes out to you guys, and as soon as they make it all look good. So these are links to actual a mock child and family team meeting we created with the CANS conversation in it. And if you email me, I'll make sure you have these links as well so that you can look. And I do apologize, they're pretty quiet, but if you put headset on, you can listen to them. And I wanted to share that I think our best success, Eileen, and feel free to add on to this, is that we've just been super flexible. Like Eileen and I have answered the same question for 500 social workers 1,000 times. And that's okay, right? Because really, they need those questions answered in a positive, supportive manner. They're learning something new. It's a big shift. I mean, it's a huge shift in how we did business. By the way, we rolled out the facilitation contact and made them start doing CANS in the same month, which was great. We just got it all done at once. So it was the first 6 months was rough. Like, I in no way want to impart to you that this was the most seamless transition in the world, because it wasn't. But now we're in our third year. We're doing our third round of recertification. We started in October, and it's just part of our practice. And we hear success story after success story. We didn't include, Laura Short shared some great ones, but I cannot tell you how many positive stories we have heard, how many great outcomes. But really the most important one to me is that parents understand their case plan. They're getting into services quickly. Because of that, social workers feel enthusiastic because they're able to start on supervised visitation month 4, month 5 of the case plan. We believe we're going to make progress on our reunification in 12 months, just because of this connection that their case plan makes sense to them. One other quick thing I just wanted to say, we were really worried about the scoring, right? Oh my gosh, how are parents going to feel about us rating their kids as 2s or 3s and them? And we have never had a complaint about that. We've done over 7,000 of these CANS conversations at this point, and it's been just positive. I think the scoring actually makes sense to parents. It's kind of like a grading system, right? At some level in their minds. And they know if they can get down to 0s and 1s, that their kids get to come home. So just my thoughts. Eileen, any other last thoughts?
Can I say one quick thing too?
Yeah,
I think
of
the
course.
structure of the CFT meeting aligns with the CANS. So if we're talking
true.
about strengths, and they can look at the CANS, be like, oh, okay, so this is a high level strength. And if we're like, wow, these are our concerns, or like, oh, now I understand why that's a 2 on the CANS. It makes it translatable, and it takes it away from being like, we are the professionals assessing you. It's part of the dialogue. That's what we see. And what we tell new social workers, don't worry about the CANS. Not worry about it. Do your questions, yet if we do the CFT process and we have an amazing CFT meeting, it will align with the CANS, and it will flow together. So I just want to mention that.
Yeah, good point.
And my final words are embrace your partners. I mean, there's no way that any of us could have done this alone. So, I mean, we really enjoy working with each other, but we're definitely stronger together. So embrace your partners.
Oh, thank you, Eileen. And you just made me think of one thing. We have to be super fluid and adaptable, right? So we have improved. I don't even know how many times we've improved the way we do this, Eileen. We were like, oh, the CFT contractor can send out our family letter in advance. They send out the CFT, the state CFT brochures. Tribal partners told us they weren't being invited to all of the meetings. We met with them and created a system. We added them to the referral form. Tribal partners shared that they wanted us to be able to have traditions and rituals at the beginning of the end of the meeting. So we included that, incorporated that into our child and family team meetings for all families, that they have the option. I think flexibility is key. We're asking our families to be flexible, and we also need to be flexible. Thank you.
Thank you, San Diego. You guys are getting a lot of love in the chat. Lots of appreciation for your time and your passion and for sharing all of this information. Olivia, are you going to help us do a wrap up? And we've got just a few minutes for question and answers.
Absolutely. Thank you so much for that. So I think we've actually reached the end of this webinar. Thank you, San Diego, Shelly, Laura, Eileen. Thank you for you and your team for sharing all your practices with everyone today. We welcome you to voice any questions or comments that you may have. After that, I just have a couple more slides, and I think we can dedicate more time for questions and answers.
Okay, so go through the next couple of slides.
Yes, please, really quickly. Just a quick reminder that if you do have any technical assistance that you need to request, please submit that through the SurveyMonkey link that we have on the screen. And then also we have on our next slide, our email address where you can also submit any inquiries, questions that you may have or concerns. Please send them to systemofcare@dss.ca.gov, and we can reach back to you as soon as we can. And then one last quick announcement on our next slide. We would also like to take a moment to invite you to present on any of your local system of care local efforts that you may have on these four topics on your screen. A quick reminder that your modeling of successful local practices is very beneficial to other counties and local agencies in the development of their own local practices. So we welcome you in presenting, just like San Diego did today. And I think that's it. We can go ahead and answer any questions that folks may have. Thank you.
Olivia, I think there was a question in chat. I think it's for the San Diego team. The question comes from Judy Weber and reads, how did you organize your services mapping?
Thank you, Ransa.
Jenny, can you field that one?
Hi, everyone. So sorry, Nancy was really right how it just takes a little longer to find that unmute button now, but
a long walk.
Quite a walk. Yes, it is, especially when you have multiple screens. So I understand the question is, how did you organize your services mapping? So I believe this is, along with our partners, a true work in progress. And this kind of all started off with our early teaming, where we started to really learn about just taking the time and learning about every partner's mission, services, what's involved with eligibility, and really mapping that out in conversations so that we're bubbling it up, not only at our level, but even to our interagency leadership team. So there is that awareness. But a lot of the work with that mapping comes within any platform available for us for that engagement and that teaming, in which we have all those system partners together. And we're really talking through about what are those unique needs. And when we have all those system partners at that table that's interacting with the youth and their families, we're able to identify the most appropriate service at that point. And then whose responsibility will it be to, one, submit a referral, or maybe if there's discussions outside of that that need to happen regarding the financial braiding of any of that. This is where the heart of, or where the heart begins discussing all those service mapping needs. For example, one of the situations that had come out was, how do we go from maybe some sort of service within Office of Education through the school day? And then how do we transition that so that there's that consistency for after school with maybe an ABA type of service? So that's kind of an example of the service mapping that occurs within a lot of our teaming.
Thank you, Jenny. That was very helpful. We also have a question in the question and answer function, and this comes from Tony. The question reads, do you integrate questions on healing in the child and family team? So many times there are underlying issues, emotional wounds, traumas, and unspoken loss that impacts the child and family's ability to be successful. Asking how can we help you and your family heal can open a powerful doorway and content you would not otherwise have access to. So I'm not sure if someone from San Diego wants to speak to healing during the CFT.
Yeah, I think that is such a great idea to ask that so directly. We have not engaged in that practice. We do, as part of the conversation, talk about those adverse childhood experiences. So we are covering, if the child has had those traumas. And that's really helpful to bring that forward as part of the conversation. I think it also helps link the impact for the parents a little bit. One of the other great things is that, when we have all the system partners present, the family doesn't have to retell that story again and again, which we know is really difficult. And actually why we stopped doing the mental health assessment, because we were having to use different providers many times, and then kids were having to retell their story. So hope that helps. And I think that's a great idea, Tony.
I just like to jump and add on to that. I believe we may have one of our system partners, Karen Culp, online, but she may not have capacity to share. But I did share this with her, and she definitely agrees, Tony. It is something that has been in discussion down here in the San Diego level. So you have energized these conversations again and really exploring within our 2083 group and even outside of that, ways to bring this to life within our teaming processes. So thank you so much.
And just to jump into, I really think that, hopefully our emphasis on the positive childhood experiences as mitigating factors to the trauma will help bring to light that, there are some of these experiences we can leverage to mitigate the trauma.
There's also a couple of questions that we've gotten about collecting all of the awesome resources that you all have discussed and talked about. So one question is, will CDSS collect San Diego's resources for counties to access? So there's been some chat with the panelists about how to help provide some of this information. And I think if we will be in touch with more information on how to access it. And then if you can always email the System of Care inbox and also request resources that way. So we will work on collecting all of this information. Is that, can I say that's kind of gonna probably happen, Ashley? Is that close to what might happen?
Sounds right.
Yes, that's accurate.
Okay, excellent. So just as a reminder, and for those of you who don't need reminding because you had a little bit of a hard time getting into the webinar this morning, we had to change the way that our Zoom links were working. We moved from a recurring Zoom link to now having every month have its own Zoom link. We apologize, that is a technical thing in Zoom, and it's difficult once you have downloaded the calendar invite on your calendar for the old link. We don't know of a way to have Zoom take that off of remove that from your calendar. So expect to have a new link for every month. So the link for March has already been emailed out, but we will email it out again. And for those of you who, it's a lot of information to kind of follow. You can email us, you can email UC Davis, you can email the System of Care box, and we'll send you out that next link as quickly as possible. So thank you for your perseverance. And we will do our best to communicate that. There's a question if we can add the link to register to the website. We're working on putting together a place on the UC Davis website where we will have access to the Zoom links. So we'll also be in communication with you about that. And if you have any questions, the inbox that's in the chat is the systemofcare@dss.ca.gov. And any last final words, System of Care team?
Thank you all for joining us today. We appreciate your time.
I echo that. Thanks for joining and sharing this space with us.
Excellent. Thank you, everyone. We hope you have a great rest of your afternoon.